paper was very, very interesting. And I'm now going to jump into skincare and how skincare influences our barrier. So we can see here that I'm going to cover a wide range of skincare cleansers, moisturizers, and sunscreens. And I'm going to start with cleansers because cleansers really are important when it comes to our barrier. You know, the focus of this is barrier and skin of color, and cleansers really affect our barrier. So the first cleanser ever introduced was traditional soap, which is very alkaline, with an alkaline of pH of up to 12. Calm bars were an equal part soap with synthetic detergents, but they were also very alkaline with a pH of up to 12. Liquid and non-greasy cleansers started to approach the physiologic pH of the skin, which is 4 to 6. So but they were still on the higher side, closer to neutral. And then Syndet bars, which are actually synthetic detergents with a very small amount of soap, have a pH close to the physiologic pH of skin of 4 to 6. And the multivesicular emulsion system based cleanser, again, has a physiologic pH of 4 to 6. And I'm really going to go into that multivesicular emulsion system cleanser in detail because there are a lot of benefits to that system. So we know that healthy skin has a pH between 4 and 6, and that's why we call that the acid mantle. We also know that traditional soap is alkaline, so it's way out of range of the normal pH of our skin. And tap water, believe it or not, is neutral to alkaline. So even just normal tap water disrupts the pH of our skin. So it's not surprising that when you look at skincare formulations, acidic skincare formulations, so with a pH of around 4 to 6, are the least likely to cause irritation. Neutral products, where the pH is around 7 or higher, have medium risk of irritation. And then, of course, alkaline products are a very high risk of irritation. So the goal with skincare is to actually create cleansers and moisturizers, and we want our patients to use cleansers and moisturizers that have as close to a physiologic skin surface pH of 4 to 6, and this reduces irritation and improves our barrier. So when we are exposed to something outside of that 4 to 6 range, we can buffer back to the acidic pH, obviously, because our skin normally is acidic, and this is called the buffer capacity of the skin. So typically after cleansing, pH can return to normal 1 to 3 hours later because we have the capability to buffer. And Andrew mentioned earlier that children, so actually newborns, are born with a more alkaline pH of their skin, and elderly, so the extremes on the spectrum of age, also tend to be more alkaline. And when you're in the middle, we're very, very good at kind of getting our skin back to the acidic pH when the pH is changed by a product or by even water, as I mentioned. But at those extremes, the skin does tend to be a little more alkaline. And luckily, infants, they return to baseline, return to an acidic pH of their skin, usually within days to weeks. But elderly patients do have difficulty, can sometimes have difficulty getting their pH back to the ideal pH for a skin barrier, which is 4 to 6. And of course, washing with alkaline soap will also cause this to become a problem. So we really want to avoid alkaline products in skincare because it interferes with our barrier. So what happens when the stratum corneum pH goes higher than 6? Well, the consequence of an elevated pH in our skin is increased inflammation, decreased stratum corneum cohesion, and an alteration of the barrier. So normalizing the pH with topical treatments really helps to repair our barrier, increases our epidermal differentiation, and reduces inflammation. So skincare becomes really, really important when it comes to pH to maintain a healthy skin barrier. So a healthy skin barrier, as I've mentioned, has a healthy pH of between 4 and 6, but it also has sufficient amounts of lipids in the correct proportion. So we have ceramides, free fatty acids, and cholesterol. All of those are part of the lipids in our skin, And a healthy barrier has the right pH and the right amount of lipids at the right proportion. And that brings me right into moisturizers, because that's really in skincare where we address that lipid balance in our skin. So the ideal moisturizer is safe and effective and cost effective. It's also additive and fragrance free. We don't want any sensitizing agents in it. It's pleasant to use. It should optimize that lipid and water content in stratum corneum. And most importantly, the ideal moisturizer should have a patient satisfaction. Patients should enjoy using it. And so not all moisturizers are created equal. When we think about moisturizers, there's three main different ways that we help to moisturize the skin. One is with an occlusive barrier, which you can see right here. And that basically barriers and film formers trap water in the skin. Humectants like glycerin bind water, so they hydrate the skin. Ideally, they're used in combination with an occlusive agent to trap the water. And then emollients, which are typically the physiologic lipids, they make the skin feel smooth and kind of get in between the nooks and crannies and make the skin feel smooth. So the ideal moisturizer has elements of all of these things. It traps the water, it binds moisture in the skin, and also gives the skin a smooth feel and appearance. So now I want to jump into this very interesting patented technology called the multivesicular emulsion system. And basically, this is a multi-phase oil and water emulsion system consisting of a series of concentric spheres of oil and water in phases. Now, in dermatology, we're very used to using systems that have controlled release of a topical. For example, in acne, it's very common for retinoids to be in a type of system where there's controlled release, because of the retinoids, we don't want the retinoid to be delivered all at the same time, because we get hot spots and irritation. But you might not be familiar with this concept for moisturizers. So a typical moisturizer that you can see here, you put it on, it's absorbed into the skin, and then its effects are over. And that's a very common complaint in our patients, where they'll say, I put on the moisturizer, but in an hour it's gone, right? That's what our patients will complain of with dry skin. Well, this technology allows the moisture to be delivered slowly over time and allows this progressive release, so you can have this long-term moisture. And I think it becomes very, very important in our patients with atopic dermatitis and xerosis. So the CeraVe, of course, contains this MVE technology, and it also contains ceramides. So ceramides 1, 3, and 6 through 11, and all of these work together to deliver moisture to our skin and deliver it long-term. Now, you might say that all sounds very nice and good and basic science and theoretically, but show me the data. Well, there's a lot of data. So these are just some of the papers that have been published that support the clinical evidence of using CeraVe cleansers and moisturizers in many skin conditions that we treat all the time. So eczema, senile xerosis, rosacea. There's nice studies that show that using a moisturizer in rosacea patients, when combined with azelaic acid, reduces stinging and burning. Dry eczema prone skin, acne. This other study here at the bottom shows that in acne patients, when you use a ceramide-based moisturizer with a retinoid, it improves not only tolerability, but even those patients did better. Psoriasis, eczema, and xerosis on the legs. So there's lots and lots of data to suggest that using a ceramide-based moisturizer is helpful in many common dermatologic conditions. So now we have a polling question, and we're going to bring that polling question up. And the question is, do you think topical moisturizers influence the physiologic lipids in the skin? So this question is asking, when we put something topically, does it change our own body's physiologic lipids? And you select yes or no. I'm so curious to see what you think, because I don't want to influence your answer, but I'm going to provide some interesting data. Okay, so 88% of people do believe that topical moisturizers influence physiologic lipids in the skin. So let's look at the data. So there's a very nice study here that looks at, it was a study looking at dry skin on the legs of women. And basically it was 49 women, 30 to 65 years old with dry to very dry skin. Now, Dr. Alexis mentioned that the problem with many of the studies that are looking at transepidermal water loss or hydration or pH or any of those things, they're often not standardized. And it becomes so important, the methodology, when you're doing this type of study. So the reason why I love this study is because it's extremely well standardized. So this was a 4-week single center study. At home, the patients used a glycerin-based soap in the morning. So they were told to wash or cleanse their body in the morning and then come into the clinic in the afternoon for evaluations. And basically, on one leg, they used a ceramide-based cream daily, and on the other leg, it was untreated. And then they looked at various things at baseline, immediately after application, day 3, week 4, and 48 hours after stopping the treatment. And many different things were measured. So the best things about this study is that it's extremely well standardized. Cleansing in the morning, all using the same cleanser, all measurements were taken in the afternoon, and they did not apply the moisturizer during the day. So it's their normal skin all day, the days that they came in for the study to be evaluated. Okay, so what did they find? So the investigator did some grading looking at dryness, roughness, flakiness, and erythema. And you can see in the dark blue column at baseline, that was all pretty severe. And then at week 4, it drops dramatically, all of them, for dryness, roughness, scaling, and erythema. What's also interesting is that 2 days after stopping the cream, so the study is over, they stop the cream, and they come back 2 days later, that reduction in all of those findings, that those dryness and roughness and all of those findings, was maintained 2 days after not using the moisturizer at all. So that's really important when I talked about that MBE technology and delivering the moisture over time, the importance of this long-lasting effect. Now, the polling question was asking about stratum corneum lipids. And how you measure stratum corneum lipids is with a method called tape stripping. So tape stripping is when you put a piece of tape on the skin and then you remove the tape. You're able to use a solvent to dissolve the stratum, the skin cells basically that you've picked up with the tape. And then you can quantify how much lipid is in the stratum corneum. The more tape strips you do, the deeper into the stratum corneum you are, and you can quantify lipids in the stratum corneum with this method. So using this method, there was an 11% increase in total ceramide content at 4 weeks. And what's even more interesting is that even 2 days after stopping the use of the moisturizer, the total ceramide content remained above 4% above baseline. And then the other lipids in our skin. So when you look at cholesterol, there was a 13% increase in cholesterol levels in the skin at 4 weeks as measured by tape stripping. And again, 2 days after stopping the use, the cholesterol levels remained 7% above the baseline. And the same with free fatty acids. There was an 11% increase in free fatty acids at 4 weeks. And 2 days after stopping use, those levels remained 5% above baseline. So this study does suggest that using a topically applied ceramide-based cream can actually change the physiologic lipids in our skin. So the next question you might have is this unique to this moisturizer, or do all moisturizers help to increase lipids in our skin? And this is the RESTORE study. This is phase 2 of the RESTORE study that looked specifically to see that. So it was very similar to the study that I just mentioned, but it compared not to an untreated site, but to a reference cream. So before we jump into the results of that study, I want to talk about phase 1 of the RESTORE study. So the phase 1 of the study was looking at how long and how much moisturizing effects topical creams have. So this was a study of 22 adults, 20 to 66 years old, with dry skin and eczema. And basically they randomized their legs, the right lower leg and the left lower leg. Site 1 and 2 had the CeraVe cream and lotion. And then site 3, 4, and 5 had 3 different reference creams, and site 6 had no treatment. So the goal was to see how much moisture do you get and for how long does that moisture last when we apply a topical cream. And what they found is that with the CeraVe cream and lotion, which are the blue and black bars all the way at the top, and I'll show you here, you see an immediate increase in moisture in the skin as measured by capacitance. So this is the water content of the skin, goes right up. And then you can see that this is maintained at significant levels, much higher than the reference creams out to 24 hours. So you can see that in a head-to-head study, basically in the same person, within the same person, you see that there is improved moisturization with this ceramide-based cream. Now I'm going to move on to the second half, which is what our polling question was asking, which is the effect on stratum corneum lipids. So we've already established that the CeraVe or ceramide-based cream can increase stratum corneum lipids in the skin, but do other moisturizers do that? So the phase 2 of the RESTORE study looked at that. So this is 34 subjects. They used the product 4 weeks, twice a day, on the right or left arm. So there was a ceramide-based cream, the CeraVe, or the standard cream. And they did tape stripping again to measure lipids in the skin. And this is the tape strip number here. So you can see here that each time you remove a tape, you are getting deeper and deeper and deeper into our stratum corneum. And you can see that the test cream increased lipid levels deep within the stratum corneum. So even as you get further into the stratum corneum and got a little bit deeper, you can still see, compared to the reference cream, there were increased lipid levels. So the CeraVe treatment delivered more lipids into the stratum corneum than the reference cream. What else did they test in this study? So they also looked at hydration, and in these two graphs, the CeraVe is the orange bars. So you can see that the hydration was higher compared to the reference cream. You can also see visual skin dryness in the orange right here was improved compared to the reference cream. So it's nice to know that we increase lipids in the skin, but clinically you also see those benefits. So you see increased hydration, decreased dryness. And then when I think of one of the most interesting parts of this study is that after 28 days, they stopped both creams. So remember, they were using a reference cream on one arm and the CeraVe on the other. And then they did this insult to test skin sensitivity with an SLS 1% patch, and that was applied on day 29 and removed on day 30. So this is a patch that basically is an irritant that can disrupt the barrier. So after 28 days of using a moisturizer on the skin every single day, was the barrier better with the ceramide-based cream or the reference cream? So as you can see here, the orange bar is the CeraVe, and you look at the visual change in redness. So there was less redness when they removed this patch in the CeraVe group, and there was also there was increased transepidermal water loss in the reference cream. So transepidermal water loss means that the barrier is disrupted. So you can see here there's more transepidermal water loss in this reference cream, and with the CeraVe, the barrier was intact. So using that cream every single day for 28 days, when provided with an insult, you still maintain that barrier. So what does this RESTORE study phase 2 show? It shows real objective improvement that ceramide-based moisturizers offer barrier reinforcement by increasing delivery of lipids into the stratum corneum, increasing skin hydration and water content, decreasing skin dryness, and also protecting the skin from irritants. So I think it's, again, very well-designed studies looking at all of the things that we would want to ask when we're thinking about skincare and barrier. Now, as this relates, let me just advance this slide. Okay, so as this relates to skin of color, it's very interesting because Dr. Alexis gave an excellent summary of how there is a barrier problem in our skin of color patients. So we do know certainly that patients of African ancestry have decreased ceramides in their stratum corneum and increased incidence of atopic dermatitis and incidence and severity. So this becomes very clinically relevant for these patients, particularly the ceramide piece, because these patients, it appears, have decreased levels of ceramides in their stratum corneum. So ceramide-based moisturizers may play a significant role in these patients. Now I'm going to end with sunscreens. And when you think about barrier, you don't typically think about sunscreen, but really when you delve a little bit deeper, the sun does disrupt our barrier. So you can see here, this is a healthy skin, and this is skin exposed to UV exposure with prolonged UV exposure. And you can see with prolonged UV exposure, there's reduced stratum corneum cohesion, there's reduced lamellar bodies, apoptotic cells, and disrupted desmosomes, which are the structures that hold our skin together. So even though we don't think of the sun when it comes to barrier, the sun really does disrupt our barrier, and we really should talk about sunscreen when we're talking about barrier. So this study looks exactly at that, how the sun disrupts our barrier and how sunscreen protects it. So we're going to concentrate on these two blue arrows here. So right above that, right here, you'll see that this is unprotected skin, 20 joules of ultraviolet light to unprotected skin. And you can see the epidermis, the barrier is disrupted. You can see epidermal pallor. It just doesn't look like a healthy epidermis. When sunscreen is applied, in this case, it was an SPF 50, the epidermis is intact, the epidermis looks healthy, and you don't see those changes to the barrier that you typically see with acute sun exposure. Again, at a higher dose of UV, 100 joules per centimeter squared, you can see, again, this epidermal pallor, the barrier has been compromised. When you use a sunscreen, you can see that the barrier is intact and maintained. So now let's talk about sunscreen containing moisturizers that have ceramides. This study looked exactly at that and found that a ceramide containing sunscreen and moisturizer routine protected against UV-induced skin surface barrier changes by preventing erythema, hyperpigmentation, improving skin hydration, and maintaining normal superficial skin cells, morphology, and turnover. So you can see here, right here is the plain SPF, and this is the SPF plus moisturizer. And I think that these studies bring to light the importance of barrier when it comes to sunscreen. We don't think of sunscreen in barrier repair, but sunscreen is really important when it comes to barrier repair. So in conclusion, there are racial ethnic differences in barrier structure and function that have been reported. Now, interpreting this data is difficult because, as Dr. Alexis mentioned, there's small sample size, varying methodologies, a very heterogeneous definition of racial ethnic groups, and a lack of standardization. So, but that being said, there are reproducible data when it comes to ceramides and filaggrin mutations. Specifically, ceramides appear to be lower in patients of African ancestry. But we definitely need more robust studies to better inform our skincare choices to maintain that barrier in our skin of color patients. The other thing, as I mentioned, is that ceramide deficiencies have clearly been shown to be obvious in darker skinned individuals. So there does appear to be lower ceramides in people of African ancestry. And I presented some skincare data suggesting that a skincare regimen incorporating a ceramide containing moisturizer has been proven to increase lipid content, including ceramides in the skin. So we should really think about ceramides when it comes to our darker skinned individuals because they may benefit from the topical application of ceramide containing skincare products.